I have to say something about Sandra's and Phyllis's presentation, because these ladies are. You've been in their trainings, many of you. We have certainly been, and the way they talk, their voice is something. I mean, we keep hearing often. I keep hearing when I'm struggling in therapy. I'm thinking of Sandra's voice. Da, da, da. It's very beautiful and it's very soothing. It was very nice to hear you present. But now we're shifting gears a little bit to talk about serious stuff. Serious stuff, also in relation to the morning presentations. So we will give you a peek into research on Theraplay. I will just briefly say something very general about a few words about the importance of doing efficacy research, also why it's hard. I will briefly outline some of the finished studies we've done since Jukka and Ilona Vierikko study. But then I would want to give more room to my lovely colleague Leanne, because they are doing a very important, a very large-scale study in the Netherlands. So I will start and then I will ask Leanne to join in. And we agreed that she will do her presentation herself, but please stay here and you can comment if you have something important to say to my presentation. Right, so it is important to do intervention studies. It's important for many, many reasons. One of the things which is, something it's good to think about is the fact that when therapists are asked if your therapy is effective, we will say yes, usually, because we get connected with our clients and most of the times it's true, we get results. In terms of research, we often tend to overestimate our own results. Now you're looking very serious at me. This is a finding we find in intervention studies. We might overestimate whether our intervention is truly effective, or we might not be aware to which components it is effective for. That's one of the things. We need to develop therapeutic interventions. I think we need to anchor them to theory, to brain research, to behavioral sciences. We need to study whether they are feasible. We need different kinds of interventions, different kinds of adaptations to different environments. We really need to check whether they are affecting the things we are saying they are supposed to be affecting. So I feel personally this is a very big goal. As a part of a research, part of a clinician, we actually really need to do more studies. It's difficult. Doing intervention studies is hard. I mean, for as long as I've been learning Theraplay, 20 years now, people have been saying, yeah, where are the studies? And we need more studies. And it's not just Theraplay, it's a lot of different kinds of psychotherapies and interventions that are facing this problem. It's very, very difficult to do good quality efficacy studies. It is, first of all, I think the question is whether it reflects the clinical reality. I mean, when we do intervention, we need to take into account many things. Do we adhere to the treatment models when we say we're doing Theraplay, but often we need to include some other elements when we're working with real life cases. So how can we know which intervention is effective and so forth? Ethical questions regarding randomized control studies. I think many of you know that's like the golden standard in empirical intervention studies. They should be done in a randomized setting where some of the people get the intervention and the others don't. So we could actually say that it's because of the intervention that they feel better or they have less symptoms. But there are many ethical questions. How can we randomize, for example, pregnant moms? Well, we did that, but there are many, many questions that we have to consider when we are doing feasible and really reliable studies. I think the final point is that they cost money. It's very expensive to do a large-scale intervention study. So I think that's something universities should take seriously. I think our politicians should really invest funding to do proper intervention research so that we could really say when they are effective and how do they need to be conducted for therapies to be effective. This is my personal opinion. It's easier nowadays to study very packaged, easily delivered interventions. Not to say that they are not important. I'm talking about, for example, at distance interventions, but I think it's also why there is so many intervention studies regarding these kinds of models. It's because they are easier to kind of put under the scientific study format. Am I making sense to you guys? Do you think, yeah? So I think we have to appreciate every effort that's been made to really try to do scientific study with regards to Theraplay, as well as other interventions, parent-child interventions. Now, we made the decision with Leanne. She's going to be referring to the published Theraplay studies in her presentation. So I'm just going to give you some brief examples what we have done here in Finland. Jukas and Ilonna's, I don't know whether it's available anymore, the study you did in the SOS villages. That was a really good book, and I urge you to go and read that if you haven't. We have a preliminary pilot Finnish study, which we did in children's outpatient psychiatric units. The data was gathered actually a long time ago. And this sample consisted of 18 children in child psychiatric care, and the mean age were between 4 to 8 years. Now, this study was done in a very rigorous way, meaning that all the people who were doing the Theraplay treatment, we had 3 to 4 therapists working with the families. They were really trained. They were Theraplay practitioners. They had monthly supervision. They videotaped all of the sessions. They used a 2-therapist model, so where there were always 2 therapists working with the family. So it was a really hard work they put into these cases. And these were children with multiple diagnoses, so these were really psychiatrically ill children. Some of them had mutistic problem, most of them had diagnosis relating to socio-emotional disorders. They were all inpatients even before any Theraplay was considered. It was not possible to have a waitlist control, so this was just a pre and a post design, but there were ethical reasons for that. The therapists did approximately 20 session treatments, but you can see there were some variations. There was a pre and post measurement comprising standardized questionnaires, but also parent-child interaction measurements, which was the MIM method in that case. And what we found out was that both the quality of parent-child interaction increased when you look at the pre and post situation. So yes, the parents who had been in Theraplay treatment, they were able to be more engaged, they were more structuring, and they were more challenging. So all the areas we are assessing when we are looking at the interaction through the MIM assessment were increased. Also, the children's symptom levels did decrease, both the internalizing and the externalizing part. So this is a preliminary study. It's just it's been submitted. It's under review, so we have to consider these results as preliminary. But of course, it's a clinical sample and it's a small sample. The results did show significant changes. So obviously we are happy with these results. Nonetheless, it's a small sample. We would definitely need to replicate these results. Well, but that's something that was done in Finland, and we are now waiting to get it published. Another study we did in Finland was a randomized control study, where we evaluated the efficacy of nurture and play, which is shorter format of Theraplay, and it's including also elements from other treatment modalities. So it's a hybrid model. It includes methods and background theory from emotional regulation theories and also mentalizing theory. So we felt the need about 10 years ago to have a really short-term, preventive, easily delivered, manualized, like a really packaged form of Theraplay with including some of the other elements. So we started to develop nurture and play intervention. And we really felt, and we still do, especially listening to Hasse and Riikka this morning, it's so important to have interventions that really directly focus also not only on the symptom reduction, but also directly on the parenting variables, on the caregiving variables, because through that we can probably also even more strongly influence the children's development. So that was the kind of the golden thing we wanted to do with our intervention, not just to focus on reducing the parental symptom levels, for example. Plus, there are not that many interventions that start already prenatally, especially if we think about early caregiving. So there are very little studies that have done that. So that's what we did. In short, the nurture and play intervention, it's really a short-term intervention. It's a manualized form of doing intervention. Each of the sessions is really described in the manual. You can start already during pregnancy, and it's aimed to be given in primary healthcare settings, so not just done by psychologists or psychotherapists, but it like a first-hand preventive treatment. In the study, which was done at the Diakoni Foundation in Lahti, where they have been piloting, they have been really refining the group model. This is done in the nurture and play group model is done in groups. So they took the first version of the intervention back in 2011, and we had the feasibility study for 1 year. So we tested the intervention with 20 mothers. We refined the model, we rewrote the manual, and in 2012 we were ready and the randomized control study started. So we screened from Lahti Well-Baby Clinic's 45 mothers who were screened for depressive symptoms. We didn't have anxiety measures at that time. They were giving, first of all, individual visits, meetings, and we did also the pre-testing, which kind of also served as part of the intervention. So we did a lot of interviewing of the parents, filming of their emotional relationship even with their tummy babies. So these were pregnant mothers at about gestational weeks were about 22. Then we did the randomization, and this was really done by a lottery. So half of the group got the treatment as usual, which is fairly good in Finland. So they got to see their well-baby clinic nurses, but the other half, 24 mothers, came to the nurture and play pregnancy groups, which were run in the Baby Magic project at the Diakoni Foundation in Lahti. I'm pointing here because Sirpa Anwal is now the head of that project. They are still running the groups. 50 mothers a year, I think, Sirpa, right? Approximately. Yeah, 70 mothers per year. Yeah. Now, when we were starting, we only had the research group. So, home visit after birth, then 7 times the groups continued when the baby was born. And then we did individual feedback, and because this was a research, we did the follow-up, where we again interviewed the parents. We did a lot of standardized measurements with these research parents, so you can see some of the measures we used here. All right, and this is just some pictures of the groups. Nurture and play, it's what it says. We nurture the mothers, so we really take care of them. I really love the way Phyllis was describing the holding environment. I think we really, and even nowadays, this is from a picture from Baby Magic room where they do still the groups. It has to be nurturing, and the way we are doing it aims to be stress relieving in many, many ways, not just what we say and what we ask them to do, but the whole atmosphere, the way we train people to do nurture and play. It's very much attuning to the child. The child is a subject. The child has an agency, even prenatally. So we prompt the reflective minds of the parents, like, you have a baby in you, what the baby feels, maybe the baby is responding. So we use a lot of lovely Theraplay-based activities to try to stimulate the embodied side of, to be really feeling connected to the babies. Some other examples, using a flashlight, for example. We don't actually care whether the baby responds or not. It might not. The point is to orient to the baby. A lot of talk about touch. I was really impressed by Hasse's findings that the touch part is so significant, because I think that's so at the heart of any Theraplay. I think especially when working with prenatal moms and babies, it's so important. A lot of direct nurture also to the mothers, because as we also heard, it's about reducing their stress level and increasing their capability of orienting positively towards the future motherhood. And we include the reflective part. It's in the manual, so it's the doing, experiencing, but also making parents more aware of the baby changes in life. With babies, we continue playing, singing, touching, all the Theraplay elements are there, and also talking about the experience. How is it for them to be with this particular baby? And the results show, in the study group, we were able to show that the reflective functioning, meaning the capability of really thinking about motherhood, thinking about the baby, it was higher in the study group than in the control group. Okay. Also, we found out that sensitivity, meaning the behavioral and affective part, was higher at the age of 1 in the study group, more so than in the control group. We also found, which was a surprise finding to us, because we didn't particularly aim at reducing depression, but we also found that the level of depressive symptoms went down more in the study group. That was a really good finding, and I think we're trying to acknowledge that even more nowadays. Right. And this study it's in press. I was actually correcting the proofs today, which means it's going to be out next week. It will be available for you guys to read. Obviously, we are very happy with these results. Nevertheless, it's a small sample study. We need to do more rigorous study, but we feel encouraged, and we want to give this to you as a, kind of like a encouragement. Start early. Okay, we should start early. We shouldn't stop when they are babies, but we definitely can influence the moms early on. So, thank you for my part.
Thank you. That was very inspiring. Well, I'm going to tell something about the research that we are doing now in the Netherlands. I feel very inspired about everything that I heard today. And it makes me a little bit nervous as well, because I feel like a little fish in this big pool of research that's already been done. But I would like to share what we are doing. I'm Leanne de Nijs. I am a clinical psychologist, and I've been working with children with autism for the last 10 years. I'm also a Theraplay practitioner and a supervisor in trainee. And when I first started working with children with autism, I already had a master degree in play therapy, and I found that it didn't match quite as good as I would like to. So we started thinking what could connect more, and we came across Theraplay, and that was something that hit me quite hard, because although children with autism are not children with attachment problems per se, but the attachment between the parents from a child with autism is very difficult. So we started applying Theraplay at our polyclinic and seeing some really good practice-based results. And I was one of the people who, when I was in training, with Betty, I wondered, where's the research on Theraplay? So that putting together, I thought, yeah, let's do some research on Theraplay, and discovered pretty soon that it is very hard to do good research on Theraplay. But we're going. So I want to tell you something about the background of the research in Theraplay. As far as we know now, there are 3 RCTs on Theraplay published some time ago, and they have quite different numbers of participants, but they have very promising results. You see they have a decrease on internalizing problems, decrease on interaction and behavioral problems, and increase of social communications, which are all signs that we see in our children with autism as well. So more to build up for our polyclinic. And RCTs are like the golden standard within research land, but it is very hard to randomize, so it is hard to get RCTs done within interventional studies. There are other studies on Theraplay, 4 cohort studies on adoptive families, polyclinical population and domestic violence, and 3 case studies on autism and neglect, which are very valuable because they give us very, very good insight information on how Theraplay can work and to build up from and so forth. But one of the main themes why we love Theraplay is that across my time as a clinician working with children with autism, I often saw parents in my room and I was like, well, maybe we should treat this parent more instead of this child, because we are very child-centered, very child-focused in the Netherlands. I don't know if it's in other countries the same, but we really missed the care for the parent. There was a systemic view on treatment, but not the view on the parent itself. So diving into the research of parents of a child with autism, we find very shocking results. These are parents who are subjects to chronic distress, toxic stress, as we talked about earlier on this day, leading to all kinds of health problems like obesity, diabetes, heart and vascular disease, depression. And some studies even show that parents of children with autism die earlier from symptoms like this, which was very hard for me to hear, because we need these parents so much, and we need them to be strong, we need them to be healthy, and we need them to be taken care of more properly. So that's one of the reasons why we introduced this study as well. I am writing a paper on play-based interventions effectivity for children with autism, which is coming out early next year, I believe. And there you can see that there are lots of play-based interventions for children with autism, but Theraplay is still really at the bottom, and we want to change that because we think we should be on top. So, what are we going to do? We are doing a randomized control trial. Just take the hardest kind of study type and go for it. What are we doing? We collect a group of in total 150 children with preferably both their parents, but if there are single parents, they can join as well. But we are particularly interested in the trios, so the parent and both the child and both of his parents, because of the lack of data on fathers. So we are including 150 children with autism between the age of 3 till 6 years old in the Netherlands, and we are randomizing them into 2 groups. The one group will get Theraplay, and one group will get treatment as usual. And this is where research is starting to get really hard, because what is treatment as usual, and can we what is it, and can we do something with it when we get all our measurements? Well, that's going to be a bit of a pickle at the end, but we're going to try to make something good out of it. Our randomization is based upon some variables of which we already know that can be of influence on treatment effectivity. So we've got like a block randomization in which socio-economical status of the parent, the sex of the child, and the cognitive development of the child are taken into account, and then randomization takes place. So we've got like 3 treatment effectivity factors already taken into account, and we hope that that makes digging through our final data a bit more easier. What are we looking for in our outcomes? Well, first, is Theraplay effective for children with ASD? That's our main outcome, of course. We want to believe that, and we see it. And like Saara said, we sometimes, as clinicians, overestimate the effectivity of our treatments. But I've seen it, so now I want to prove it. But we also want to investigate whether Theraplay is effective on the parental distress. And that's why I was so enthusiastic about that you had findings about the depression going down. That's very hopeful for my research as well. Because the parental distress is like a very big factor to take into account. If parents experience higher levels of stress, it induces more problem behavior within the child. And more problem behavior within the child induces higher levels of parental distress. So you get like the vicious circle. And we really want to see if Theraplay does something to this and can break this vicious circle. And also we want to see what is the effect of Theraplay on the parent-child relationship as a whole. And the last part that we are looking at is if hair cortisol can be seen as a potential biomarker for the treatment effectivity of Theraplay. But don't ask me a lot of questions about this, because this is actually the part of the second PhD within this project, but I do have to mention it here. She made this beautiful slide. We are collecting hair samples from the children and the parents at start 6 months and 12 months because some previous studies have shown that hair cortisol is like a very good and stable marker to investigate stress levels within people. So we want to see if Theraplay has effect on stress as well physical and psychological. So we take hair as a biomarker for this, next to the psychological questionnaires that we let parents fill out. Our measurements are quite elaborate, and this was also a difficulty which Saara talked about, getting it through the Medical Ethical Commission, because parents don't get anything from it. They just have to invest more time. So we're asking people with chronic stress levels to invest more time. So that's a bit of a paradox. But they approved it. So our measurements consist out of, I would say, a trifecta. We have like the questionnaires filled out by the parents on their own behavior and on their own health and psychological health, but also about their child. Then we have questionnaires for the teachers about the child's behavior. And we have like clinical observations for the child, one of the child itself with the ADOS, and we use the FEAS for the parent-child interaction. And then we also have like the physical measurements in which we try to achieve a cardiovascular profile and also the hair cortisol as a biomarker for the stress levels. So where are we? Oh, no, this is in an inclusion criteria. So if you have any, please join now. Where are we now? Well, we just finished our first year of inclusion. And this is already an old sheet because we are now at 30 inclusions. That's not quite 150 yet, but we're going strong. Luckily, we have a lot of resources in the Netherlands. From my own company, which is called USE, we have 11 infant mental health polyclinics who joined our research with a total of 52 Theraplay practitioners at our disposal. So we do have quite big enough capacity to pull this research off. And next year we are expanding to a multi-center study, which the MTC has to approve for at its own again, so we gain 4 another polis. is it called clinics? Yeah. So we hope to get a more faster inclusion in the second and the third year and start analyzing our data afterwards. And this is our poster to get more people to join our study. Yeah, and we're on our way. We hope to get some good results maybe next time.
Wow, I have to say, amazing, right? For everyone practicing Theraplay, and so I'm really personally looking forward to the results. I mean, this wouldn't work as an advertisement in Finland, so we couldn't get more participants with this, but it looks really beautiful. So, have you already started doing the treatments?
Yeah. Yeah,
So
we
could
have
you say
like,
something?
Yeah, we have like 30 active, how you say it? 30 active participants. So it's like now, I think 15 Theraplay trajectories and 15 treatment as usual trajectories, which is quite interesting because treatment as usual is varying very much.
So they get a lot, as they should.
Yeah, or not.
Or not. Okay. So how many here work with autistic children or children on the spectrum?
It's a lot.
It's a lot.
Yeah.
It's a lot. Yeah. Anything you can share? And of course you have experiences also as a therapist, like
Well,
how does it work?
I don't know quite yet how it works, but what makes me very happy every time is that when parents come at our clinic, they are just surviving. They're surviving to get by, to get around. And when we start with the Theraplay, it's almost like they see each other for the first time again and have like these little moments of joy. And those little moments of joy, only once a week maybe, is enough for the next week. So that's something I think people who work with children with ASD might recognize as well, and that's why we should make this work.
Yes, Leanne, and kind of I'm just looking at your expressions. Many people are like nodding, so we are resonating to this, and just kind of wanting to say that we know, many of us know this, and I didn't mean that we overestimate our results, that they are not true. I just want to say again here, it's so important to get this out and published. Also, nowadays we really need that too, so this is why it's so hugely important that you do. Jukka had a question here.
I'll just take this so you don't have to repeat it. Thank you very much, Leanne. I had, at the moment, I'm not working with autistic children, but when at the children's clinic and then at the small child outpatient clinic, of course, we did. And I resonate very strongly with what you said about these moments of joy, and was, like you, shocked by the trajectory of illness and early death. Yeah. It's just so important to realize how toxic stress is not only causing illness and shortening the life of children, but also of parents. And I haven't seen that previously, but it resonates so well with the ACE studies of children, with the same illnesses increasing and life shortening. But then when you did, that was the autism spectrum, and the parents, like you mentioned, are different from some of the attachment disorder children parents in that they are often trying tremendously and looking for ways to contact with their children. And when they find it, like through you or your colleagues, there is the healthy side, which immediately sparks up to joy. And if we think of Barbara Fredrickson's conceptualization of joy, in a way the biological meaning of joy as being something that broadens and builds, it opens up the central nervous system for new possible experiences
Yes.
and builds. I think that what you're seeing probably is this, that this one moment in a week broadens up the view and builds for until the next meeting. And
Yes.
so the parents tend to be different, and what I remember is that they were the most grateful, even in the long term.
Yes.
And if I have time in the afternoon, I'll just show a couple of clips of these, one with an autistic child and one with the other one was with severe developmental delay. And the reason we can show them is the parents are still years and years and years after so grateful for what happened.
Yeah, I recognize that.
So, does anyone else have a comment or a question you would like to ask Leanne or Rika?
Thank you. I have interest. I think some of the parents might be also from autistic spectrum disorder. So how do you treat this? Do you include them in your study or? Yeah.
Yes, we do. We ask them about that in the questionnaires about themselves. And we do have a lot of experience with Theraplay and autistic parents as well, because we have like a lifespan clinic, so we treat children but adults as well. So we have actually a lot of parents with children with or without autism who receive Theraplay as well, and we see good effects on that. So there's no exclusion criteria. Makes it more fun afterwards to look what it's doing.
Okay, so first I want to thank you for great presentation, and I have to say you have an amazing study here going on. So
Thank you.
yeah, and so we will have a very important findings from this project. So thank you for that. But I would like to ask from you that because of your specific like group, including only autistic children, have you taken this into account of how you provide this Theraplay treatment? So do you have like some that we are going to focus more to the joy or play or something in relation to Jukka's comment? So have you done any kind of this?
No, actually
just-
not.
yeah.
No, we find that the semi-structured protocol of Theraplay might be the force of Theraplay, because every Theraplay practitioner can make it fitting to the needs of the patient itself.
Okay,
Yeah.
yeah. And another question, what do you think, what's the role of the age of the child here? So you said that you are focusing on the children between 3 to 6, which sounds very reasonable, I understand. But what do you think, why you selected that age variation?
It was actually for two reasons. One, because of the role of the mother within this age group, because it's far more permanent and less of peers and less of teachers involved. And the second reason was because most of these children are free of previous treatment.
Okay.
So we have like more of a clean sample.
Yeah, but I also think that from the child developmental perspective, it's good that it's under school years. I mean, during that years, so much going on still on your regulation and attachment, also into children with autism.
Yeah.
So that's very good. Yeah.
Okay, there's a question also.
I'd like to concur that, this is a wonderful, wonderful contribution, not only to Theraplay, but for children with autism. We know that children with autism have quite a range of functioning. And you said, so a couple of questions. One, you said that you use the ADOS as part of the selection criteria. So in terms of intellectual functioning, are you seeing children with quite a range of functioning?
Yeah. It's not an exclusion criteria, but we do take it into account when we are going on our analysis afterwards. Yeah.
Oh, okay. And then do you anticipate that the Theraplay protocol itself would vary according to either the severity of the child with autism and maybe their intellectual level, or what do you think?
I think it does, but that's just based purely on my own experience as a clinician. But it would be very good if we could say something about that with our data.
Yeah. There are so few studies that involve the parents and their own functioning. And one of the key things that I find as a clinician is that taking Theraplay home, both practicing in session, but then being able to impact functioning in the home is just a whole nother layer. So I think that, first of all, having parents in the sessions, working with them, and then having their stress reduced, can only be an improvement all the way around. So thank you.
Thank you.
Okay, thank you so much again, Leanne. And let's go.